Welcome to Conversations with AcroPsych, where we create inspirational and educational material on psychiatry and addiction. I'm your host, Dr. Matt Campbell, and today I'm really excited to be joined by Joshua Collver-Horvath. Josh is a licensed clinical social worker. He's an experienced therapist and also founded a group practice here in California, Fair Oaks Behavioral Health, and he has a lot of experience providing custody evaluations, working with couples, as well as providing cognitive processing therapy, which helps people heal from trauma. Josh, welcome to the show.
Thank you so much for having me.
So the cognitive processing therapy, I realize we're always throwing in acronyms in mental health. Do you mind giving a little brief summary of what that actually is for people?
Absolutely, of course. And I know it's like the alphabet soup with all the acronyms for therapy. So, cognitive processing therapy, we call it CPT, and it comes from cognitive behavioral therapy, which was an approach created by Aaron Beck back in the 1950s. And cognitive behavioral therapy, in a nutshell, really focuses on an individual's thinking, their thinking patterns, the way they understand the world through thought, their attributions about the world, and how our thoughts impact our feelings. And in turn, they cause certain behaviors to happen, which also impacts our thinking and our feeling. And so you can see this triangle here forming. And out of CBT, cognitive behavioral therapy, there have been many, many useful treatment approaches that, branched out from that original model. CPT is one of those. It is a cognitive behavioral therapy, but specifically designed to help people with PTSD and treating that. Cognitive processing therapy was created by the amazing trio, Dr. Resick, Dr. Chard, and Dr. Monson. And I've done training with Dr. Chard. She is fabulous. This treatment approach has been around for quite a while, started in, I believe, the 80s. It originally started to help rape survivors and veterans coming back from active combat. CPT is a bit unique in its model. It's actually a very fast, efficient treatment, 12 to 16 sessions, and it's a very safe approach. When I say safe, it's because in the clinical world, you want evidence-based treatment that is shown to help people, and CPT has robust findings behind it. It's had over 14 randomized controlled trials. These are like the gold standard in clinical research. Very hard to get a randomized controlled trial. They've had 14. It's been taught and used around the world for people in all different groups of people, races, ethnicities, socioeconomic status, and it's been shown to be effective for everyone.
Very cool. It's a very exciting type of treatment. And I know, when we're going through training and we're, as psychiatrists, referring to people, sometimes we're used to like a textbook answer. So CPT, cognitive processing therapy, is like, this is a great place for us to start. If you could give me advice as a psychiatrist referring people with trauma, how could I think about CPT compared to maybe prolonged exposure or EMDR as alternative options that we would be considering?
Right. These are all great treatment approaches available out in the therapeutic world. So people, I think one of the flashy ones is EMDR. A lot of people are talking about that right now. Research shows that cognitive processing therapy works particularly well for people with guilt, possibly experiencing a lot of self-blame, where there's a lot of internalization of the trauma that has happened. With CPT, we often find ourselves helping people that have been impacted in their lives by rape, incest, molestation, loss. It could be incredibly abusive relationships like domestic violence, survivors of crime, veterans in particular. This treatment approach has been endorsed by the VA as the premier trauma treatment to offer people. And we often see people with extreme betrayal. CPT is really good for that in particular. Prolonged exposure therapy, I don't think as many people have heard about this one. What the research shows is that CPT, for people that come in with PTSD, about 70% of them will show full remission of symptoms. It's very robust outcomes. I think that even beats out some medications. Prolonged exposure therapy is a little different, where that's really good for people with some of the core trauma symptoms of hypervigilance, startle reactions. They're just hijacked by the trauma in a way where they're having a lot of physiological kind of responses. And EMDR, it's very popular, but it does not hold the same weight in clinical studies as CPT and long-term exposure therapy, which are about neck to neck.
Would it be fair to say someone who is much more about the internal thoughts about themselves and the world, that those are the people that are absolute best, which may be a little different than the people who have that physical feeling that they're trying to address more? You're saying those people might fit a little bit better in prolonged exposure?
Sure. Would it be okay if I gave an example?
That'd be perfect.
Okay. So I'm going to self-disclose here for purposes of what we're talking about. Also, this is what pulled me into CPT. When I was 13, I got hit by a car going about 50 miles an hour on Halloween night. I was out trick-or-treating with some buddies and almost died. And after that, it was a very, very lengthy recovery for me. This was back in the early 90s, and they were giving out codeine and other opiates, which interestingly perfectly masked trauma symptoms. So when I finally got off those medications and started to recover, boy, was I flooded with a lot of the hypervigilance, the startle response, the almost irrational fears that come with trauma, and was able to navigate through that. And many people recover from trauma on their own. That is not an uncommon thing to see. But that was an accident that occurred, my trauma. And I think what the research shows is that trauma that is willfully inflicted with malice or cruelty from another individual has a more damaging, lasting effect. A case study, that we use in the training for this was a woman in her 30s. She had a great guy best friend. They had been friends for years. He was a really protective friend. They were drinking buddies. They'd go out to bars, and he would often pay. He would ward off kind of problematic people, and very protective, helped her a lot. And then came to her and said, "Hey, I'm actually very attracted to you. I'd like to have a relationship with you." And she said, "You know what? No, we're good friends. I don't want to mess up our friendship. I'd like to remain buddies if you're okay with that." He said, "Yeah, sure." So they went out drinking that night to kind of ameliorate things, got very intoxicated, came back to her place, and it wasn't uncommon for them to crash on the couch or the bed. And she woke up to him having sex with her. And she said no, passed back out. And in the morning woke up and this person said, "Hey, I'm so glad we took our relationship to this level. I can't wait to see you later." Well, she fled. Complete PTSD trauma type symptoms started to show up in her life after this, really created a lot of problems for her. And in treatment, she would say things like, "I think this was a terrible misunderstanding. I must have led him on. I must have done something wrong here. I should have known better. I should have seen certain indicators that this would happen." With CPT, it's almost a surgical approach. We are really working with people's thinking around the trauma. And what you will find with trauma is that people need to construct a reality. They need to make sense out of this really horrific, terrible thing that has happened in their life. And the brain does that in really interesting ways.
Mm.
And sometimes it'll go into the past and say, like, "You should have done this. You should have known this. You should have seen this. You should have been able to," in the case of an active shooter, like somehow save 5 people. Or it goes into the current present and it's like, no one can be trusted. You have to keep safe at all costs. So a trauma is like somebody opened up your skull cap and put a red hot poker on your brain, which was never supposed to happen. And your brain doesn't have arms to throw the poker off. What your brain has is its ability to think, and it will do its best to try and figure out why that trauma happened and how to stay safe. So CPT is very rational, it's very logical. It makes sense and focuses on people's thinking, what they're telling themselves about the trauma. And we really use a funnel down approach to focus on what people are telling themselves about why it occurred.
So say this person's now in this situation where she's had these kind of beliefs about herself, beliefs about the external world. What would it actually look like in a session of you trying to do that surgical approach to address these thoughts?
Of course, CPT is a very safe approach. The patient is always in control. We give them a good map of what they can expect. They get a manual. In my practice, we print it out. We love when people write by hand. There's a CPT app people can use. And we start by doing a lot of education around trauma. What is trauma? Why are we doing this treatment? And really explaining the powerful role of avoidance and isolation with trauma, because PTSD loves avoidance. Avoidance is like the oxygen that feeds the PTSD fire. And we begin by helping that person write what we would call an index event. This is not write about the trauma, go into dense detail about the trauma. We have them write about what they think caused the trauma. Why did this most distressing event occur? And then we have them write about, how did it impact you, your views about yourself, and your views about the world in these 5 areas: safety, trust, power and control, esteem, and intimacy. And these are on a hierarchy of importance here, because trauma will for sure impact every domain like that in your life.
I could see a lot of overlap as you're talking about avoidance coming up with my work in substance use, and I can see why it's such a common experience for people to have some version of PTSD with substance use, and those comorbidities come together so often. When I notice a pattern of avoidance, it's usually not the easiest transition to make. My whole, world, I've gotten used to avoiding this problem, and I maybe don't see myself as being able to face this. Would you say CPT helps people face that avoidance in a way that is different than some of the other ways within mental health that we try to help people change that avoidance to expose themselves to higher gradations of the problem.
Avoidance is a fascinating human reaction to pain. If you're going to be a human being living on planet Earth, you're guaranteed pain. We really need to address and be with pain. Now, if you touch a red hot stove, you're going to pull back. You avoid it naturally, and that works. But for deep internal, psychological, emotional pain, particularly from a trauma, an event that your life was compromised or your deepest integrity as a person was compromised. One rape survivor I worked with said, I knew he wasn't going to kill me, but he took everything else from me. A trauma can also be like if you find out something really horrific has happened to somebody you love, that can be traumatizing. Like when I got hit by a car, of course I had PTSD symptoms from that. So did my mom. That'll mess up a parent. Avoidance is, of course, going to be there. We don't want to do those things. And what people with PTSD often do is they're coming up with ways that they deeply believe will keep them safe in life. Sometimes they're very extreme reactions to trying to stay safe. And how we identify that in CPT is we help people pick out what we call a stuck point. These are usually very powerful thoughts that people come up with about their trauma, why it occurred, or what they need to do to stay safe. An example of that might be no men can be trusted. A veteran coming back might say, there is no such thing as safety. I can never be safe in life. Those would be good examples of stuck points. They're usually very concise, very matter of fact, very black and white. And people feel that these are keeping them safe in some way. But really, it's like bars that you're putting up. You're safe in your cage, but ultimately you're in a cage. You're not going to thrive or live a meaningful life in that. So we work artfully with avoidance. We work with people's beliefs. We process with them. That's why it's called cognitive processing therapy in the session. We use a lot of Socratic dialogue. It's not trying to correct people's thoughts, but helping them become more balanced and effective for them. And avoidance does show up, and we actively talk about that in session. We call it out. That's part of the treatment. There's a lot of homework in CPT. If you don't do it, you're going to do it in the session with me.
As you were talking about that view of how the kind of cage that we're building or the prison that we're building for ourselves with this avoidance, it reminds me a lot of ACT therapy and this idea of creative hopelessness, where we really take what we're currently doing right now and how we've tried all of these other things, right? Like the people at this point have tried to make life work for them with this kind of avoidance pattern, and it's not getting them the life that they want. And helping create that contrast, I think, can be a really powerful piece of taking a risk, right? To come see you, to come see a therapist and find a new way to address this problem.
CPT is it's almost surgical in its approach. I mean, we use a funneled down approach. We get right in there. And essentially what we're doing is kind of like the story of the Wizard of Oz. We are pulling back the curtain, and there's just a little man there pulling levers, trying to make the world work and keep things safe for himself. And once we pull back that curtain and address it and take a really good look at it, the guy gets to go home. He's happy. He's okay. It's better. He's improved. He's not so busy spending his life trying to pull levers and stay safe. Now, acceptance and commitment therapy, beautiful approach. The big difference is, whereas acceptance and commitment therapy is really focused on accepting, they would not be focusing on symptom reduction. An ACT therapist would really be focusing on acceptance, not trying to change your thinking, but rather accept it, be present with it, and come back to your values and living life in a valued way with committed action towards what you want to do. There is a lot of concept overlap with CPT and ACT, but CPT is very focused on we're working with your thinking, and we are working with changing the thinking because we've learned that it's better that way. If you look at the brain, you've got your reptilian brain in the back, keeping all the systems on go. The middle brain, the big emotional part of the brain, the amygdala is there. All of our feelings are there. It takes up the most real estate. And then we have the prefrontal cortex, which is your executive functioning. I call it the motherboard, the newest evolutionary part of the brain. Well, when you're traumatized and you're living in PTSD, your amygdala is on overdrive. It's going like 150 miles an hour in the fast lane to a dark neighborhood you don't want to go to. And what the studies show is that with time and untreated PTSD, the prefrontal cortex atrophies. It is not doing as well. So CPT is very focused on not focusing on emotion as much, but focusing on the thinking and getting the prefrontal cortex back online with helping you think, getting out of that emotional part of the brain and getting the prefrontal cortex working more effectively for you. We want people to feel and think effectively with this treatment.
Thinking back to that example that you had earlier, I don't know if that specific person has engaged in therapy long enough to have kind of an outcome, but does she, or do you have a different example of how someone felt the benefits of CPT and how it affected their life after completing treatment?
That's a fantastic question. So that case that I referenced earlier with that woman, throughout the treatment, the first half of treatment is really working on your thinking. We're putting you through worksheets. Really, you're getting a black belt in like cognitive behavioral understanding of your thinking. The next half of treatment is about the themes in life that the trauma has impacted, that safety, trust, power control, esteem, and intimacy. And those work two-way street. You get internal responses and you get the world and the people in it. Now, that woman, she really was struggling with calling it rape, really identifying what happened to her, the impact it had on her. She struggled. But at the end of treatment, she was able to say, yes, so and so was a really good friend. He was a great guy. He did a lot for me. We were really bonded, and he raped me. And because of that, I can no longer be friends. I can't have contact with that person. I choose not to, and I'm choosing to live my life differently now. That is a good outcome. That is a more balanced, effective thought for her that isn't feeding the PTSD bonfire.
She's actually able to see what's been done wrong or incorrectly by the world and outside of herself, as opposed to taking on that as something wrong with her.
God, yeah, it wouldn't be uncommon for a trauma survivor to come in. And one rape survivor I worked with, it was her ex-partner, and she really felt it was the clothes she was wearing. And she would tell me, I know this is so ridiculous to think this, but I really do think it's the clothes I was wearing and the fact that I went in his house that contributed to this. The brain is desperate to make sense of what happened. Why did this trauma happen? And of course, we go internal with that, right? Like, I did these things that contributed to it. Really, that's very different than somebody breaking the law and violating you.
What would you say to, I know I've had the experience of working with people where sometimes they cognitively, like they in their thoughts, they can be like, yes, I know this person's wrong, but in my body, I don't feel any different. Even though I can say I know that these thoughts and these truths have changed in my mind, I'm thinking of the body keeps the score. And some people are very interested in this idea of my nervous system and a physical healing in trauma. Is that something that comes up very much in CPT? And if so, how would you say that model works with that kind of challenge?
I love that you're bringing that up. I think that's really important because, depression hurts the body. Anxiety and panic attacks definitely have a physical result. Trauma really has some physicality to it, especially with the core symptoms of startle response, hypervigilance, that kind of thing. In CPT, there are 20 symptoms that, constitute PTSD. And we are working on PTSD. We're not working on this trauma or these 5 other traumas that happen. We are treating the PTSD and we focus on the core index event. There's usually one trauma that was the most painful, the most difficult. It's usually the trauma nobody wants to think about. We focus on that. And as we go through this treatment, we are actively scoring you. So you'll be getting screeners to test your symptoms. And what has been shown is that when people really commit to the homework and they do this work, they automatically show a reduction in those physical symptoms. It does take a little bit of time, and we'll tell people, you're doing great with changing your thinking. It does take the feelings time to catch up to that. That's not uncommon. But the majority of the clients that I work with in this trauma treatment, to be honest, they grumble in the beginning. They're like, this is a lot of work. And I'm like, okay, well, there's 169 hours in a week. We meet for one, and you've got to do like 20 minutes of homework. And they, oh, okay, it just feels bigger. It feels, that's right. That's the avoidance showing up. So let's commit. Usually, after a little initial grumbling that sometimes happens, they hit a stride and they're like, this is working. Something's changing. I feel better. This is different. And by the end, one client told me she had been attacked by her mother. It was a really horrific incident. And, she said, this changed my life. I am just liberated. I'm a different person now because of this. And that includes those physical symptoms. They usually follow suit. But we have learned in cognitive processing therapy, there are so many studies on this treatment approach that really show thinking, because humans have to make sense of this world that we're in. We construct our realities, and we definitely construct realities around why this traumatic event occurred and what it means about me and how it impacts us. So we've learned to target that and focus on that.
You mentioned in that an example with another potential challenge in treating trauma, which is this idea of one discrete event versus multiple traumas. Figure some of the people had lots of trauma and repetitive types of traumas. The word complex PTSD is thrown out there. If there have been multiple traumas, does that change whether or not they can do CPT? Do they need to adjust how they're doing CPT in those kind of instances?
Right. I think that is such a relevant question because in our practice, we often get people coming in, and part of their standard intake process is we give them a screening tool to screen for trauma. And many people score surprisingly high. We go, "Hey, did you know that you scored like really high in your trauma screener?" And they go, "No." And I said, "Yeah, you scored like in the 40s, which indicates PTSD, indicates it. It's not a confirmation of the diagnosis, but they'll often say, well, the most traumatic thing was my family. This constant low grade abuse or invalidation, this chronic cruelty from a parent or an unloving parent or a parent who couldn't show up. Or we often get a parent who gave a sibling access somehow to a child and the sibling did something and there was no accountability. And interestingly, oftentimes in those traumas, the most painful part is not the abuse that occurred. It was the invalidation by the parent. It was when my mom didn't believe me. One youth I worked with was raped by a family member, went to mom, and mom said, "I don't believe you. You're making this up." It completely invalidated the child. And he said that was the most painful thing for him. At 11, he was able to identify that. And so to answer your question about the complex trauma, in this lifetime, people are likely to have a trauma that occurs. And many people, given whatever happens in their life, have multiple traumas. Judith Herman wrote a brilliant book on this called Trauma and Recovery. I'll put that reference in the show notes. It's a classic. But life guarantees both physical and psychological pain. When we talk about CPT, we work to identify the index event. We have ways to guide people to really identifying what that was for them. With a little bit of work, it will come shining through. You will know what that index event is. And we're not treating each complex trauma that occurred or complex PTSD. We're treating PTSD. So it's kind of like if you're pregnant, you're either pregnant or you're not. Well, you either have PTSD or you don't. And we're going to use the PTSD. And we focus on the index event and what the research on CPT shows. This is really interesting. When you focus on that index event, the treatment reconciles to the other traumas. People see improvement. They're not as impacted by those other traumas, and they show an improvement in their relationships with people around them.
So even if they have 10 significant traumas in their life, if you focus on that most important one, the rest of them will receive benefits as a secondary effect to taking care of that primary one. Is that what I'm hearing?
Yeah. And it wouldn't be uncommon for somebody in treatment to, like one woman I was working with, she was a rape survivor. She had to escape her domestic violence relationship she was currently in, and that was traumatizing when she was attacked. We folded into the treatment. Same treatment applies. We just add it in, we work through it because it's very skill based. People are learning very, very powerful skills in order to navigate these things effectively in their life. We don't guarantee that you're not going to have a reaction. Of course, you're a human being, to whatever's happened, but we want you to be living effectively with it. And that starts with our thinking and how we respond to it. So if there are multiple traumas, they usually do come out. Also, wouldn't be uncommon for somebody in treatment. They're doing the work, but it might not feel like they're really gaining traction with where they want. And it wouldn't be uncommon for a different index event to show up. Actually, this is and I couldn't say it before, but I can say it now. There's enough rapport, trust, and ability for me to know about trauma and what it does to now say, actually, this is what happened. And then we just add that in. They don't need to write a whole new index event. It comes out in the worksheets that we do with them. Like I said, it's really homework based. So I call it the brain meat grinder. We're like really putting it through this process to make sense of everything in a healthy way.
Yeah, it makes sense. We've come to this place in our life over a lot of repetitions and a lot of practice that we've now established this as the norm. It takes some practice to change that and move in a new direction. I see trauma a lot, as one can imagine. And where I did residency, I would say it was an inner city in the Bronx. There was a lot of sexual trauma that was experienced by a lot of the people we would be working with. And there was one person in particular who I got to work with during my addiction fellowship for a year. And I felt very overwhelmed at the beginning to start with this person. She had a lot of this kind of early life trauma, and she had gotten to the place where alcohol and benzos was really how she avoided and coped with what she was struggling with. And she was going to the emergency room a lot. She was very much in this kind of dire place. One thing that I think struck me during that time is I did have time as a fellow, and I really prioritized a lot of time working with her each week, taking it step by step to reduce one of those substances and build coping skills alongside of that. It was really incredible for me to see once she took care of the substances, she was able to take care of a lot of those problems on her own in a way that there's just this huge ripple of her life changing by taking care of the top problematic issue for her. And it seems like that's something similar that you're hearing, this kind of idea of you take care of the biggest index event, that there's this ripple effect that happens throughout the rest of their life.
Yeah, that can happen. I'm really glad you bring that up because substance use is so prevalent in trauma work. In a study by Kessler, this was a meta-analysis, and I think it was in the early 90s. It indicated that approximately like 46% of people with PTSD were going to use substances to cope. It's one of the numbing symptom clusters that we see with PTSD is people are tired of being in their trauma, being impacted by PTSD, and they often use substances to cope. And in my career, I've been a manager in psychiatric hospitals, I'm a manager in emergency rooms doing 5150s. I've worked in federally qualified healthcare centers and drug and alcohol treatment centers. I see trauma everywhere. I would say 80 to 85% of the people in there had had a pretty significant trauma and would probably score pretty high on a trauma index or significant units of distress, another measure we use. And a good bulk of them use substances because they were using a substance to cope and they built a dependence on that substance through the process. So sometimes, trauma treatment can really help with that. It wouldn't be uncommon to see people make changes through that. And then other times people really need specialized help around substance use to make the right kind of changes because alcohol, marijuana, particularly opiates, benzodiazepines, these are very, very helpful if you have trauma. They work fast, you have easy access to them, and they will mask your
Relief.
symptoms. Yeah, but what you're gaining in whatever relief, you will be paying for exponentially later. So they're made to be dependent on these substances and they're hard to get off of, even if you consciously want to get off of them. We do a lot of work around that in the practice too, that will come up with trauma treatment. So sometimes you'll see relief and then, and people can get better on their own from that. And sometimes they need additional help.
It's a good point. I hope that story wasn't to illustrate that this one thing fixes all. At the best, she would be doing therapy to address her trauma. And I think even when she was off substances, that would be greatly beneficial for her. Her relationships were not solved at that point, even though a lot of things did improve from it. You specifically work with couples as well. How do you see the intertwine of trauma and relationships and couple work that you do?
It would not be uncommon to be doing couples therapy or family therapy for that matter. And you quickly will realize like somebody has a really significant trauma history in their past and it's definitely showing up in this dynamic. One woman I worked with, she was more mature, later age, and was trying to date to rebuild a connection. But on dates, she was screening for risk. Whereas these other parties were like screening for, are you going to be fun? Are we bonding? Are we enjoying each other? And that was not what was happening on the other side of the table at dinner. And so it shows up really quickly. And when I work with couples, I use emotionally focused couples therapy developed by Sue Johnson. Beautiful treatment approach. Sue Johnson, just one of the world's most brilliant couples therapists, and unfortunately she passed away recently as a real loss to the therapeutic community. Emotionally focused couples therapy works on emotion and how we're emotionally responding to our partner, attending and attuning to our partner or our family member. Emotion really is the royal road to change there. But what the research has shown is for CPT for trauma, like you really want to work on the thinking. So sometimes there is CPT for couples and trauma. There is a branch of CPT that does that. But it wouldn't be uncommon for me to say, as an adjunct, let me link you with a trauma therapist or let me do the trauma work with you and let's come back to the couples work. Because remember, with trauma, it's going to impact your sense of safety, trust, power and control, esteem, and intimacy. These 5 primary domains in our psychology are critical for forming a healthy, secure attachment with a person. Of course, it's going to impact your partnership, and your nervous system and feeling safe and psychologically safe with your partner. So it can really show up particularly with sex. If you've been sexually abused or sexually assaulted, oh my God, that will really hijack your ability to show up that way and enjoy intimacy with your partner. A lot of people that have trauma would say like, I need to get drunk to have sex, or I need to be high in order to do that. And it's a real loss. So I would recommend, if you do have a trauma, you would probably want that as an adjunct to treatment. It's hard to be in a partnership when you have like a chronic like adrenaline dump in your brain, and it's just really hard to show up the right way.
You talk about those five domains. For many people, that the relationship is ultimately the piece that they come to treatment for. It's either the symptoms that they're feeling that they want relief from, or the way in which the relationships are not what they would like to be. That's one of the most maybe fruitful things. In addition to feeling better, is their life actually changes with the amount of relationships and the quality of relationships they're able to form.
Absolutely. That's right. It wouldn't be uncommon for somebody to go through CPT and their partner will be like, they've changed.
Mm.
Like there's a significant change here. Things have shifted positively. But for many people, your relationship with your partner is one of the most important things in your life. And trauma will impact that. Particularly, we will get referred men. Men are, we're not built to seek out therapy, or we're not taught that socially. We're taught to just kind of hunker down, cope, don't talk about your emotions very much, and just, muscle it and get through it. But sometimes we'll get people coming in, they're like, my wife's going to leave me if I don't do some work here. And we uncover that there was this horrific trauma that happened, and it's really having a huge impact. Let's work on that. I get a lot of men coming to my practice because I'm a male, and I think there might be a comfort level there. But man, they might be a little stoic in the beginning, but once they're in therapy, they love their therapy. They talk and they really make good of the work and enjoy it quite a bit. And they change,
Yeah,
they improve.
that's a really good point. I'm thinking back to my time in medical school where in the past all of the OBs used to be male. I was going to medical school in a time where it was predominantly females, and so patients want to be around a female because understandably it's a very vulnerable place to be, and they felt more comfortable and they didn't necessarily want me to be there. And I've noticed, at this current time that a lot of the therapists are female, and I I will say there's not as many options for men who are really reluctant to open up to find a male that they maybe at least see culturally as similar to themselves. It doesn't seem to be as common for them to have that kind of option.
Yeah. It's, I kind of jokingly say it's really hard to find a good therapist. They're like shoes. You got to find the right pair, the right fit. But what the research shows is it's not really so much about race or ethnicity or socioeconomic status. What the research has shown is that sometimes that will lead to longer duration in treatment. But if it's a good fit and the therapist has unconditional positive regard, good empathy, non-possessive warmth, which is, you don't want a therapist who's cloying or overly concerned, you want somebody with the right balance of qualities. There's great outcomes with that if you have those three therapeutic effects. And almost all of the evidence-based therapies are shown to be effective. All roads lead to Rome with a skilled therapist, a good fit, and somebody committed to the work. You will show improvement. I think that's really hard for people because trying to navigate managed care to find a good person in the mental health system is tough. It can be.
Do you actually mind sharing a little bit of maybe common barriers or common apprehensions people have to entering CPT or trauma type therapy? And how would you address those for people?
I love that because, yes, it's frightening. It is frightening to have had a traumatic incident or event in your life completely transform you in the moment of a few seconds, or whenever that trauma happened. It's alchemical. You become a different person instantly. You begin living your life incredibly differently. You've been hijacked. I've heard some people describe it that way, that like I no longer had my life. It was taken away. It's scary to sit with somebody and have enough trust and go like, you want me to change my thinking about how I live in the world? Well, what I've done so far has kind of kept me safe to a degree. And you want me to change that? That's really, really frightening. And so we help people very gracefully through that process. And it does take trust. It's a big commitment and it's a big ask to have somebody sit there and be willing to change the way they view the world and think about it. But we guide them through that. And the work does a lot of that itself when they actually do the work. They come to these answers. I sometimes jokingly say, like, I'm just your process consultant here. I'm just going to guide you through this. You're going to be the one getting really good at doing this work. And by the end, oftentimes with these worksheets, they'll zip right through it and they go, and here's the answer for myself. And this is what it really means. And they get quite good at it.
It's awesome. That's always good to see when people are mastering the material and they get to go on their way and, they've really internalized that expertise for themselves and they don't need a therapist or medication or something, that they really have gotten to a place that they're at that level of healing. I think that's always really beautiful to see. You're providing so much, great information, great discussion around treating trauma. For people who would like to learn more about you, where would be a good place for them to find you on the
Absolutely.
internet?
They can go to our website, which is fairoaksbh.com, and it'll be in the show notes. Or they can go to my other website for family law if you want, Joshua Collver, LCSW.com. Just type that into your Google browser, it'll come right up. And feel free to email. I will answer your emails. I'll respond and happy to answer any questions. If you are looking for a CPT therapist in your area, you can go to cptforptsd.com, and there's a whole CPT roster of certified therapists all over America, I believe, and even I think some out of country as well.
And so that's a resource that they have, a directory of people who've gone through training, that they know how to do this type of therapy, and they can find them in their region if they're outside of California.
Correct, yeah. And to do CPT well, it takes training to do this treatment effectively. And so if you were seeking out a therapist, I would say, tell me about your training in this. You have a right as a consumer of a service to know that.
I think that's such an important thing. And part of where I think a lot of this podcast got birthed is I get a lot of questions around substance use or, how do family members support people? We see these sites popping up. People now have more access to therapy or to psychiatric treatment, but we don't always know what the kind of quality of that access is. And I think those kind of resources, like you're saying, really empower people to find people well trained to do the treatment that's going to help them.
Yeah. I mean, if I'm going to work on this trauma, this horrific thing that happened to me, and I do have very powerful beliefs around why it occurred and how I need to stay safe, I want somebody doing a treatment approach that is effective, which CPT has been shown to, and I want somebody trained in it, somebody who can really take good care of me. And I personally consider it sacred work, when somebody comes in and they are willing to open up this chapter of their life or whatever had occurred and trust me with that work with them. That's really important. I want to do a very good job with them and help them heal and recover in their life, because really, we get this one life and we want to live a life of meaning, free of fear and doubt and living in trauma.
It seems like CPT is such a good tool, and I want to wrap up today, another conversation with AcroPsych, but really just appreciate Josh coming on, taking the time and providing so much insight around cognitive processing therapy, trauma, and healing from trauma.
Thank you so much. Thank you for having me.
Thank you for listening to this episode of Conversations with AcroPsych. I'm your host, Dr. Matt Campbell, and I specialize in psychiatry and addictions. If you have questions about psychiatry or addictions, I host a regular Q&A for therapists, providers, and the general public. You can find more information about us at www.acropsych.com or on all major social media platforms at AcroPsych. We kindly ask you to subscribe to this channel on YouTube or rate us 5 stars on Spotify, since it helps expand our reach and inspire more of our audience.
This episode and all material is purely for general education and not personal medical advice. It does not establish a doctor-patient relationship, and we recommend you working with the appropriate physician or other healthcare provider before applying it to your situation.